I got a full one now.
All right, so let's start lecture 26. We're going to finish up our transfusion processes. We're going to talk about some special transfusions in this lecture, such as autologous transfusions, directed transfusions, and things like that. All right, so you guys remember we talked about autologous transfusions. They are the safest transfusion, all right? You receive your own blood. However, there is a caveat to them, and we're going to talk about that. We're going to talk about a type of autologous transfusion, including preoperative collection, all right? So if you're scheduled for surgery, you can go to the donor center a couple weeks prior to that surgery and then donate a unit that you could be transfused. Typically, they only do this if you're expected to have like a high blood loss surgery, so like a vascular, orthopedic, those types of surgeries. If it's just a simple, non-invasive procedure, then probably going through the process of an autologous donation is not worth it. The number one thing about autologous donation is it is a bit more expensive, all right, because that unit has to be specifically tagged for a specific person. And then sometimes people will donate and then that autologous unit is saved for them and then they don't use them. All right, autologous units can never be used for anybody else. They will never go into the donor pool. All right, so if that unit is not used for yourself, then it is discarded. All right, so it could has the potential to be very wasteful. And we're going to talk about normovolemic hemodilution. That's one way to reduce allogenic transfusions, and then blood recovery, also known as auto self-salvage or self-saver, okay? Then we're going to talk about directed donations, and we're going to talk about if autologous units or directed units can be entered into the donor pool and why or why not, all right? And then apheresis products, and we're going to talk about bone marrow transplants. Okay, so autologous transfusions, that is your own blood where you donate blood for a designated time. Usually it's a scheduled surgery. And a lot of people feel safer doing this. It is the safest transfusion. A lot of people feel better if they're having surgery, knowing that that blood is available rather than being exposed to a random donor unit. Keep in mind, I want to say this about autologous transfusions. If these units are transfused outside of the donor collection facility, all right, so if you go and donate, but then your surgery is scheduled at the hospital, that donor facility has to transport that unit to the hospital. That's where it will be transfused, okay? That unit will undergo all infectious disease testing, just as our regular. However, if you test positive for an infectious disease, the unit will be marked as positive, but it is still able to be transfused. It is not rejected like we would with a random donor, all right? It's just clearly labeled, this unit is hepatitis B positive, but it is designated for a specific patient that is already hepatitis B positive, okay? That is the reason why autologous units can never, ever go into the donor pool, okay? That's because if it did test up positive, then the recipient, all right, you're accepting your own blood, is aware of that, okay? So that's why autologous units can never, ever be used by another person. Autologous units will be labeled just like a usual donor unit. However, it will have additional labels on it. It is going to have the recipient information. Usually you'll have the recipient's name, date of birth, the receiving institution, so where that surgery is scheduled. So if you were having scheduled surgery at St. Vincent's, it would have the St. Vincent's Hospital location on there, the address, the date of collection, of course, and then the expiration date, okay? And it will be clearly labeled, it's color-coded. Usually autologous units have a big, bright green label on it that say for autologous use only, okay? And then at the hospital side, what you guys will probably be more involved in, the receiving of these units. So when you log it into your inventory, you will actually input your patient information and attach it to that unit. That lets your computer know that that unit is not in the donor pool. Okay, it cannot be used for anybody else. So your computer will know that. And like I mentioned, the blood is collected prior to the procedure. Usually you have to have a physician order, all right? So the physician has to say that you are able to donate this unit, and it usually has to occur, the donation has to occur within 72 hours prior of the scheduled surgery. Okay, so usually you're gonna do it like 2 or 3 weeks in advance, but it has to be at least 72 hours before that scheduled procedure. And again, it's usually given when a large amount of blood is expected to be lost, such as orthopedic, vascular, some type of surgery that's going to be very bloody. If you are an individual that has a rare blood type, maybe you have an antibody to a rare antigen that's very hard to find antigen negative blood, or maybe you're Bombay, then autologous will be highly recommended for you, right? And again, not indicated if it's not really going to be a very invasive procedure, if it's not going to expect it to be a very bloody procedure. The procedure is more expensive, again, because that unit is being tagged for a specific person, and then there is the risk for waste there, like I mentioned. Typically, if you start donating way ahead of time, you can donate a couple times. So like if you're scheduled for a vascular surgery that has the potential for a lot of blood loss, you could go in maybe 2 times and donate 2 units to be used during that procedure. However, we don't want our patients to develop anemia because of that, all right? So they still have some hematocrit and hemoglobin requirements. It's a little bit lower than what our random donor pool is, and we're going to talk about that. Especially, let's say you are a Bombay type, all right, so you have a very rare phenotype, very rare blood type. It might be even where the donor center and the physician works together and they give you erythropoietin to stimulate red cell production. That way we can collect as much blood from you prior to that surgery because you are such a rare type. And that would be like Bombay would be a really good example of that. All right, so autologous transfusions are not restricted by age like our routine donors are, okay? It's more of a weight thing, right? And so they still have that minimum weight of 110 pounds. However, if you have a donor that is wanting to do an autologous donation and they're lower than 110 pounds, we could adjust the amount of blood taken from them, all right? And so here's your hematocrit. Remember, for a routine donor, the required hematocrit is 38%, right? For autologous, there is a lower hematocrit requirement, 33%, all right? If you have a patient that wants to do an autologous donation and they're already anemic, that's the #1 reason that autologous donation is not possible for them, because they already have that low hemoglobin. And if your patient is septic at the time of donation, then that we don't want to have them donate either, of course. All right, so we don't want them to be already contaminated. Yes. No. So bacteremia is very specific, meaning that there is bacteria present in your blood circulation. Septic really is, it's kind of a more broad term, like the patient is septic, meaning that they have an infection. Is it necessarily in their blood, or where else could it be? So bacteremia is a little more specific, but usually septicemia, bacteremia, they're usually used interchangeable, with bacteremia being a little more specific. And if you think about at the donor center, the units are going to be gone through all of the usual testing. Remember, however, I said that infectious disease, that unit will just be labeled, all right? It's not going to be discarded or rejected. And then the receiving hospital will confirm the ABORH again, all right? So here's some advantages and disadvantages. I took this from your textbook. The advantages for the recipient, it prevents transfusion transmitted diseases, right? So they're getting their own blood, prevents alloimmunization. That's just because they already have those antigens. Those red cells are the exact same as in their circulation, so they won't be alloimmunized, meaning that they won't be sensitized and they won't build any unexpected alloantibodies. Supplementing blood supply, so that patient scheduled for surgery will use that unit rather than taking up our donor pool, our donor inventory that that hospital has. Prevention of febrile and allergic reaction, again, it's your own blood, it came from your circulation, and then it makes the patient feel better, all right? So they're more confident in receiving that unit because it is their own blood. Disadvantages, inventory control. That receiving hospital must maintain that that unit not be transfused to anybody else, okay? So there must be a mechanism in place that that unit is never transfused to anybody else. Another disadvantage, we don't want to cause those donors who are scheduled for surgery to go into anemia from donating, okay? Increased cost, high wastage, like we already mentioned, and then increased incidence of adverse reactions to donation. All right, so if the patient goes in to donate and then they have an adverse reaction from the process of donation, whether it be vasovagal, maybe serious cardiac, all right? So there's that risk too. There's another type of autologous transfusion. It's called intraoperative hemodilution. And I've actually mentioned this briefly before, but what this is, think about your patient, they're in the OR. Okay, what they're gonna do is they're gonna pull off 1 unit of blood, then they're going to, and it can stay out at room temperature, or they can put it in a temperature controlled refrigerator. And they can keep it up for 8 hours. So they're gonna take that unit of blood off, then they're going to replace that patient's volume with either saline, Ringer's lactate, right? And then after the procedure, they will transfuse that blood back to the patient. Now, how often this is done, I don't know the statistics. Here at UAMS, I don't think they routinely do that. They would rather use cell saver, all right, which we're going to talk about, which is red cell salvage, or give them allogenic units, all right. This might be a good option for patients who are anemic, because if you think about it though, we're taking blood away from them and then giving them volume expanders. So they might, but it reduces the risk for bleeding during the surgery. So if you're lowering their blood volume during the surgery, but then you're going to replace it directly following the surgery. And then, so this is occurring inside the OR. So BloodBank really doesn't have any control over this. But they must label that unit for autologous use only, all right? They will label it. That's just in case something happens in the OR and that unit is left there, it still has the patient information on it, okay? Then we have intraoperative blood salvage. This is performed at UAMS, and when I worked in blood bank at UAMS, we actually did this. This is called cell saver. And so what happens is we had instruments, we had brought tubes, and you had all of this tubing and you hooked your machine up, and everything is maintained in a sterile field. So you worked very closely with your surge tech, okay? So they had all of their instrument, everything is kept aseptic, and everything is sterilely wrapped. And so you would have your tubing, you would hand it to the surge tech. He would open it and on his sterile field, and then he would hand the tubing back to you and you connect it to your instrument, and then the suction the surgeon uses during the procedure. All right, so what this does is during the procedure, any blood that is lost, they have suction right at the site of surgery. Okay, and so whatever blood is lost is suctioned into the instrument. It has a centrifuge, all right, so all of that blood goes into a reservoir. Usually when you reach a certain amount, maybe like 250, 300, 400 mils of blood, you move it, you start your machine, and it suctions from the reservoir into the bowl. and then saline is added. That bowl centrifuges. It does a series of washes, and then the washed red cells are pushed out of the bowl into a transfusion bag. And then you can sterile clamp that bag and you give it to anesthesiology at the head of the patient, and they transfuse the patient with it. Now, this is a really good option for Jehovah's Witness, okay? Jehovah's Witnesses, it is their moral beliefs that they do not accept blood from anybody else. They feel like blood is the blood of Christ, and it has healing powers, and they would rather die than accept blood, all right? However, if we maintain cell saver in a closed system, meaning that it never leaves the tubing, they will receive their own blood during surgery via this option, okay? So if any of you guys know somebody that's a Jehovah's Witness and they're scheduled for surgery, they might actually request cell saver. And the only difference is usually we clamp off that unit and give it to anesthesiology. If your patient is a Jehovah's Witness, we must maintain a continuous system. We will not clamp off that unit. So that unit will be at the patient's head on a pole, and once we wash our bloods, the tubing is continuous. It goes straight from our bowl to that unit to the patient, okay? And they will use cell saver anytime you have a procedure that is scheduled and it is going to be a lot of blood loss. So any type of trauma, gunshot wounds here at UAMS, they will always use cell saver. Any type of vascular surgery, aortic aneurysms, cardiovascular, orthopedic, that's another huge high blood loss surgery. And so they like to use cell saver. It prevents, there's an advantage of cell saver is it prevents your patient from being exposed to allogenic donors, okay? So it decreases the risk of being exposed to infectious disease and foreign antigens that they might build antibodies to, right? So keep in mind there are some instances where you don't want to use cell saver because you are suctioning blood out. If they're performing surgery at a site that contains tumor cells, if your patient is known to have cancer and there is a malignancy present, we don't want to transfuse those malignant cells back to our patient. So that would be one instance where cell saver is not warranted. Another would be if they're doing any type of abdominal or bowel resection where there's the potential for bacteria to be exposed, then that is not a proper instance for cell saver, right? We don't want the patient to become septic from bacteria that was suctioned during the procedure, okay? I mean, this is just kind of what it looks like. Here's your instrument, here's the broad tube that I mentioned. So here's your patient here. Your surgeon's probably right here. Suction's coming in right here. All right, so here's your reservoir that I mentioned. Notice that it is full of red cells. At the point that you get probably to about 250, 300 mils, I would start washing, right? So you're going to start your instrument. It's going to suction blood from the reservoir into your bowl. Here's your bowl right here. Blood's going to come in. This bowl is a built-in centrifuge, so it's going to spin. Then saline is added. It's going to do a series of washing the red cells. It's just washing away any type of excess protein, anything that they might have used at that site, anything they might have given that patient to prevent bleeding. They will wash that away. And then you have to be careful. There are some exceptions. There are some clotting factors that they will give the patient during surgery. You have to make sure that they're not using those, all right? And then once it's washed, it goes from the bowl into, they don't have a unit hanging, but it would be here. The unit pushes the red cells into your donor bag. And then if you had a Jehovah's Witness, you would have another tubing from your donor bag to your patient. This is a very interesting process if you're ever involved in it. It's in the OR, so it is very stressful, especially if you're in a high blood loss situation, trauma, gunshot wound. You never know what might happen. Patient status, all right, they could be bleeding out. There are instances where the surgeons will yell at you for more blood. You're doing everything you can. Sometimes if it's a high bleeding case, this reservoir is going to be full. and this is going to be a continuous process. It can be very busy for the cell saver person. But you control the suction, right? So you control how much blood the surgeon can pull in. You control the process of washing, and then you control giving that blood back to anesthesiology. So surgeons will yell at you if you're ever involved in this, and they will say, I need more blood. Increase that suction. All right, what happens if you increase suction on your red cells? It damages the cells, lyse the cells, all right? So you have to be aware of that. You just tell the surgeon you are doing everything you can, all right? It's not your fault your patient is crashing, all right? So, and you can always tell them blood bank has red cell units available if this is not enough, okay? I worked with one of my coworkers. She had a really bad experience in the OR. Surgeons were yelling at her. The patient was crashing. She literally came back down the blood bank in tears. So don't ever let that happen to you. It is not your fault. All right, you are doing everything you can. So if you ever get this experience, it's something to see. You are in the OR, so you do have to scrub down. You have to wear your face mask. You will have goggles on, and then your surge hat. And so you have to help maintain that sterile field. So, but it's interesting, but can be very high stress. This schematic kind of demonstrates what's going on inside your instrument. So here's your saline, right? So you usually have 2 salines. That's what you're washing with, right? That's what you're washing the cells with. Here's the blood, right? So here's your reservoir. Blood is coming in here, goes through the tubing into your bowl, right? This is where your red cells are. It's going to wash. It's going to centrifuge. Once you do your washing, then the red cells will be forced up into your, what they call your reinfusion bag. Okay, and so all of the excess saline that you wash with, it's forced out during the centrifugation process, and you have a waste bag. And so you also, keeping that in mind, if you're doing this continuously, going through a lot of blood, your waste bag is going to get full. So you have to keep your eye on your waste bag. You might have to switch it out. Depending on how. Now, some surgeries are there and you don't give any blood back because it's not a very high blood loss surgery. But sometimes you'll be constantly getting blood back. Just depends on what type of condition the patient's in and what type of surgery. Now, there are, I don't know if any of you guys have heard of perfusionists before, but they are specifically trained for this. They go to school to learn how to do cell salvage. And typically in cardiovascular cases, they will have a trained perfusionist. I think there's only like a couple perfusionist programs in the United States. And so they typically would handle, at UAMS anyway, they did the cardiovascular surgeries. Blood bankers would do the orthopedic and the aortic aneurysms and all the other vascular cases. So if that's something you're interested in too, you can check into that as well. And again, this intraoperative blood salvage, also referred to as cell saver or auto cell salvage. And so here's a really good example of kind of what it looks like in the OR. They're using a different instrument. It's not the bot tube, but it's still, here's your bowl centrifuging right here. Here's their saline, there's their reservoir with the blood in it. So the blood comes in here, goes into the bowl, and then will go up to their reinfusion bag. Notice they're real close to anesthesiology. So there's your anesthesiologist, there's your patient. And so if you have a Jehovah's Witness, you will work with anesthesiology to maintain that continuous flow for them. Right, so that's autologous donation. You can donate ahead of time before a surgery. You can do volumetric hemodilution, or you can do auto cell salvage. Right. Directed donations is if you decide to donate for a specific person, right? Maybe you have a family member that's scheduled for surgery. That is a directed donation, okay? That unit will be tagged for that specific person. There is, research has shown that there is a disadvantage to directed units. So let's say you have a friend or family member that asks you to donate. You know, they're nervous about their surgery. They're nervous about having to receive blood products. And they say, hey, would you be willing to donate for me? Number one, they do have to go through the donor questionnaire, all right? So it's just like a routine test. Think about all of those questions on the donor questionnaire. Maybe they don't want to admit that they are being deferred for a reason, all right? Maybe they have a positive test. Maybe they have engaged in an activity that will defer them, you know, if they have needle marks, or maybe they've had sexual contact with a specific person. All right, that would defer them from being a donor, and they don't want anybody else to know that. All right, so if you have skeleton in your closet, sometimes directed donors are not very honest. Okay, so that is research has shown that, it's documented. So that's the number one downside to directed units. Okay, even though we're going to do all of our infectious disease testing, all right, some might not be forthcoming with that information because they don't want their friends or family to know. All right. And remember, with directed donation, if it is from a first-degree relative, your mom or dad, your brother or sister, those units must be irradiated to prevent graft versus host disease. Okay. However, if you do ask family member, friend to direct donate for you, and they have a very good experience, and they say, hey, I like that, I'm going to become a routine donor. Well, we just increased our donor pool. So maybe they become a repeat donor as well. Not for necessarily a directed, but maybe for just a random. Okay, so we do have the potential to have them become a routine donor. There are some contraindications where we wouldn't want a specific individual to donate for somebody. An example of this is if a wife is scheduled for a procedure and then the husband would donate blood for them, that could affect her in their wanting to have a future family. That could affect her future offspring. All right, so think about RH in this instance. If mom is RH negative and dad is RH positive, and number one, that's probably not going to be able to be a donation anyway, but in the event she was transfused those RH positive blood, she would build anti-D, which could be detrimental to the fetus in a future pregnancy. Okay, so that's the reason. And then also HLA antibodies is a huge concern too. So if mom is transfused products and exposed to those HLA antigens on the cells, then mom is going to build HLA antibodies to which her future fetus might be positive for. All right, does that make sense? So then mom is going to have the antibody which will attack baby cells. Okay. Sometimes directed donations, your person that wants to donate for you might not be compatible either through ABO or HLA, like we mentioned. And then, like we mentioned, donor might not meet the volunteer donor requirements. Again, those skeletons in the closet, they might not be forthcoming about. All right, so we've answered some of these questions. Should an autologous unit be entered into the donor pool? The answer for that is no, never. However, directed donations go through the same donor questionnaire, the same infectious disease testing, and then if your directed donation does end up becoming positive, then it is rejected and it's not accepted. Okay, so the directed units could potentially be inputted into the donor pool. Okay, however, different facilities handle that situation differently. So if a hospital receives a unit and it is specific for a person, if that person doesn't use it, then it gets discarded. So each facility might handle that differently, okay? So directed units can be entered, however, it's at the discretion of the facility if they choose to. You have to look at your facility's SOP on what it says, okay? And again, what if an error recurred relating to issuing the unit? Autologous units, you want to make sure they only go to the designated donor. All right, if you're using a computer system, it has to have the capability to know that that unit is attached to a specific patient. And remember, your autologous donors If your autologous donors test positive for an infectious disease, it can still be used, all right? It will just, that unit will just be labeled. That is why it can never go into the donor pool. There's an error on this slide. It says only the ABO and RH is performed on autologous. That is at your donor facility, or sorry, your receiving hospital. Okay, at the donor facility, they're still going to do infectious disease testing. Okay, all of the routine testing is performed. The only thing is if it pops up positive, then it is labeled as such. So the receiving hospital will know that that unit is infectious. Okay. All right, so then there's some apheresis products. And apheresis is a category of blood collection where a specific product is obtained, and then the other components that are not needed are given back to the donor. Your donor selection is the same as a regular donor, so they still have to go through that questionnaire. They still have to have the weight requirements, the hematocrit, and all of that, okay? So if any of you guys have ever done apheresis donation before, this is what your instrument looks like. You have two different options. You can have intermittent flow, just involves one arm, right? So the needle is in this arm. They will do the entire collection, all right? So they'll pull a whole unit of blood off. Let's say they're keeping plasma. So then they're going to spin the product down, express the plasma off, and then through the same tubing, the same needle, they're going to give your red cells and platelets back to you, all right, keeping the plasma. Okay. If it's continuous flow, that means that both arms are going to be used, and they will continuously be spinning the product down, taking off the plasma, and then the red cells and platelets can go back into the other arm, maintaining a continuous flow. All right, so intermittent, continuous, both are acceptable. It just depends on how your donor facility is set up. Okay, but what happens is in your instrument, blood comes in, kind of just like our cell saver. It has a centrifuge in there. It has anticoagulant that's going to be added into there. Spin it, keep the product that's desired, whether it be platelets, whether it be plasma. They can even do red cell pheresis and granulocyte pheresis. So they'll keep the product and then give everything else back to the patient. Okay.
Is it the same needle size as whole blood?
It is 16 gauge. So types of apheresis: leukapheresis, platelet pheresis, plasma pheresis, and then you can actually do, if your hematocrit is high enough, you can do a red cell pheresis, and you can even donate 2 units. All right, if you do a double donation in the same day, then your time in between, remember you can donate red cells every 8 weeks. So if you do a double donation, then you have 16 weeks before you can do another red cell pheresis or red cell donation. Okay. Notice that in order to be a double unit donor, your hematocrit has to be greater than 40%. And usually there's a weight requirement too. For males, I think you have to be greater than 150 pounds. Females, you have to be greater than 130 pounds in order to do a double red cell pheresis unit. Okay. And then you have to have that hematocrit. So hematocrit and weight play a huge role. Oh, so plasmapheresis. So we're keeping plasma, all right? That's the desired product. You can actually donate every 4 weeks for plasma, okay? If you're a frequent donor, meaning that you're going in there every 4 weeks, they're going to want to monitor you. They're going to want to monitor your protein levels, your total protein, your IgG, your IgM. So they might draw blood for you and measure your protein levels before they'll let you continue to donate every 4 weeks, okay? So if you're just coming in every 8 weeks, then they won't worry about your measurements. But if you're a frequent donor, meaning you're coming in as frequently as you can, then they will take these measurements for you. And then we have cytopheresis. This could be your white cells or this could be your platelets. For platelets, you can donate platelet pheresis every 48 hours, okay? But you cannot donate more than twice a week. All right, and then you should not ever donate more than 24 times per year. All right, so while you can donate every 48 hours, you don't want to donate too much, right? You need to give your body time to replenish that platelet count. And usually before you are able to do a plateletpheresis, they will take your platelet count, and it has to be at least 150,000 per microliter. Okay. So if you're low, if your platelet count is low, then they're not going to let you donate platelets, right? And then the total amount of volume that it should not exceed 15% of your donor's volume. Again, because we don't want to cause any adverse effects for our donors. All right. All right, and then we have red cell apheresis. Typically, let me say this about granulocytes. Typically, if we are keeping a granulocyte, remember, granulocytes have a 24-hour expiration time. So usually if we're collecting a granulocyte, it's going directly to the hospital. Typically it's from a patient that has already been infectious disease tested. And so because we have to give that 24-hour window, okay? And sometimes what they'll do for the donors is they will give them a colony stimulating factor to promote the production of the granulocytes so we can get a therapeutic dose from them. All right, so remember, think about your Buffy coat, it's very small. All right, so that's what we're keeping the white cells from that Buffy coat. So we can give them some granulocyte stimulating factor, and then we'll take the white cells from them. Okay? And then here's your requirements for red cell pheresis. That hematocrit must be greater than 40%. For males, they have to have 130-pound requirement, and then females 150 pounds. And you can donate a double unit every 16 weeks. Sarah asked if that was mixed up. I probably said it backwards a while ago. So it's 130 for males, 150 for females.
Can you donate just a single unit?
You can donate just a single, yeah.
Is the same requirement?
I think for a single unit, the hematocrit is what plays there. But in order to do a double unit, that's when the weight comes into play. So as long as you're 110, all right, so that's your regular donation, and you can do a single red cell donation if your hematocrit is high enough. All right, so let's talk about transplantation. And we've established this before, especially when talking about bone marrow transplants. Your ABO of the bone marrow is not as important as the HLA. That is oftentimes why after a bone marrow transplant, we can see our patient's type change. All right, so they want to get closer of an HLA match versus a ABO match in your bone marrow. All right, so what does that mean for blood bank? And we're going to talk about that. All right, so if you think about organ transplants, your liver, your kidneys, your heart, your corneas, skin grafts, right? They're doing all kinds of transplants these days. ABO compatibility is critical for those organs such as your liver and your heart, all right? But for those tissues such as bone marrow, such as cornea, ABO is not a huge concern. It's more about HLA to prevent the rejection of those tissues, okay? This just gives you an outlook of how blood components are used following a transplant. Take a look at your liver. See how many products typically a liver patient is going to have. 20 units of red cells, 6 units of platelets, 30 units of FFP. So those liver transplant patients, it's a very bloody process, very bloody surgery, and then following the surgery, they will also be transfused, all right? So your liver transplants are the ones that are going to be highly transfused. So if you work at a facility that does liver transplants, they will receive a lot of products. And then notice that your kidney transplant uses minimal products, your heart, and then your liver. So you have two groupings of liver. If your process goes well, doesn't use very many products, but if something were to happen, whether the procedure had an incident during surgery or your patient has any problems accepting that liver, then that's when you'll have the increased products, all right? Here at UAMS, they do liver transplant. We have our liver patients receive a lot of products. It was not uncommon for them to receive this in one day, all right? And so if you think about bone marrow transplants, what are they obtaining from the bone marrow? They are getting those hematopoietic stem cell that's what they're looking for, is those stem cells. That's what we want. And it has become a more common procedure. From those hematopoietic stem cells, they can do a couple collections. They can do it from a bone marrow. They can also do it from peripheral blood collection. And then they can also do it, of course, from the umbilical cord that we talked about, all right? The cord blood. So they're using these hematopoietic stem cells for treatment of some blood conditions such as leukemia, any type of bone marrow failure, aplastic anemia, any type of immunodeficiency syndrome. They're even using HLA matched bone marrow transplants now for sickle cell patients as well, and major thalassemias as well. And again, HLA matching is the key thing in these hematopoietic stem cells, because your hematopoietic stem cells don't have any ABO antigens. Okay, they don't have any ABO antigens expressed on the cell membrane at this point in their maturation. They're stem cells. Okay. So just to give you an option of how these hematopoietic stem cells are being derived, most of our hematopoietic stem cells now being collected from peripheral blood. So they could do the apheresis technique. We could give them some colony stimulating factors, stimulate the production and the release of those stem cells. We could also do the bone marrow and then cord blood. So notice now that your peripheral blood is the leading, and it keeps increasing. All right, for 2014, 65% of stem cell collections were done using the peripheral blood technique. So it has become a lot less invasive for stem cell donors. All right. It used to be where if you were going to donate stem cells, you would have to aspirate a bone marrow, and it's a very invasive procedure for your donors. It used to be harder on the donors than it was the recipient, all right, because we actually had to access the bone marrow, and then we're going to talk about the treatment of that bone marrow before it can be transfused. They would give it intravenously, so those stem cells have cell markers on it, and they would migrate to the bone marrow. And then that's where they would reside and continue the maturation and proliferation. Okay. So the apheresis using peripheral blood, that's the most common type at the present time, and we use those colony stimulating factors. Again, if you think about a bone marrow, it's a less invasive procedure, just having a needle stuck in your arm versus having a bone marrow aspirate. All right, so if they were to use bone marrow, there's a procedure that they have to follow. Think about what's in the bone marrow. You have spicules, you'll have some fat in there. All right, so we're not concerned with all of the other components of the bone marrow. We only want the hematopoietic stem cell. So it's going to go through a process of filtration. They can even freeze those stem cells for future use. And that is what they do for patients that do auto bone marrow transplants. So they'll do a bone marrow, then they'll treat them with chemotherapy, radiation, wipe out all of their cells, then they will do that transplant after their treatment of chemotherapy. Okay, they will remove the malignant cells that were present in the bone marrow before they transfuse it in that patient. So remember, we're only concerned with hematopoietic stem cells. So during that treatment process, they could also get rid of those red cells. Again, that kind of decreases the need for ABO match, right? And then we definitely want to irradiate these bone marrows before transfusion as well to prevent graft versus host disease. So this little schematic lets you know if the bone marrow is used for collection of the hematopoietic stem cells. From that bone marrow, it's going to contain red cells. We're going to have our white cells. It's going to have platelets. It's going to have spicules. It's going to have fat. Okay. So here's what we collect. They collect the bone marrow. It's harvested from your donor. And then it's going to go through a filtration process. All of the red cells are going to be pulled out. All of that spicules will be caught. All of that excess fat can be spun down and pulled off as well. And then we're left with our hematopoietic stem cells. This is what would be irradiated, all right, to destroy, or not destroy, but prevent those mature T lymphocytes from proliferating in the recipient. Okay? And then it's given to the recipient intravenously. All right, so that's why I said it's a lot more invasive for your donor than it is your recipient. And so once those stem cells are transfused into your patient, they will migrate to the bone marrow for proliferation and maturation, right, to stimulate normal cell production in your leukemic patient, your sickle cell patient, or a bone marrow failure patient. And so this just kind of breaks down. They're going to remove the red cells. Again, that comes into play for ABO compatibility. They're going to remove the plasma, remove the T cells, all right, through irradiation, deactivate them, remove any malignant cells, all right. So if your patient already had leukemia or some other disease, they would remove those malignant cells, and then they can actually freeze those bone marrow cells to use that at a future date. So if you think about the population of patients that receive stem cell transplants, they usually have undergone chemotherapy, or they have some type of malignancy in the bone marrow that prevents production of cells. So oftentimes these patients will receive multiple products, right? It's very important. These guys are considered immunocompromised. So we need to make sure that we give them irradiated products, right, to limit the graft versus host. And then also leukoreduced, okay? And remember, we leukoreduced to reduce the alloimmunization for HLA antibodies, okay? We don't want to cause them an adverse effect from the transfusion, and HLA antibodies could cause a febrile transfusion reaction. Okay? These patients are also considered immunocompromised, so they will also need CMV. But remember, leukodepletion is now taking the place of the requirement for CMV negative. So most facilities can avoid the need for CMV negative by doing leukoreduction. And then even after the transplant, the patient is still considered immunocompromised. They will always receive irradiated products and leukoreduced products. All right, so like I mentioned earlier, HLA is more important for our progenitor cells. ABO is not so much of a concern. And that's just because those stem cells don't have the ABO antigens on their membrane yet. So what happens if your patient is transfused cells and they start producing red cells from a different type than the recipient? In our testing, they're going to have a different type of cells in their circulation. We could see our patient's type start to change, okay? So it's possible you could have a dual population. You'll have some of your donor cells that are still in circulation, or that are in the circulation, and then you'll still have some of the recipient's own cells in the circulation because they're still living there 120 days.
Were there antibodies to the antigens on the blood?
So that's a good question. So directly following the bone marrow transplant, the patient's antibodies, you could actually see a little bit of a major incompatibility occur, but you're going to have some slight hemolysis. But then once those donor cells start producing and the antibody is cleared, then that will clear itself. So that's why in blood bank, we always pay attention to what our patient type is. Once your donor's type is evident in your ABO typing, you honor the donor's type, all right? So if your patient was an O and they received an A bone marrow, their type is going to start looking like an A. We can give them A products, okay? So I have a chart that demonstrates that in just a second. All right, so here's an example. If an O person, all right, that's your recipient, gets a marrow from an A donor, the recipient is going to begin to make A cells and still have anti-A. All right, so you will have some slight hemolysis directly after that bone marrow transplant. Again, that would be a major incompatibility because your recipient's antibody is attacking the donor cells, okay? So here's your major incompatibility. If your patient is O, but your donor is A, your recipient antibody is going to attack those cells. Minimal, all right, at the initial, and then once those red cells start being mass produced, then it will take, all right. Minor incompatibility, if your recipient is type O and your donor is type, recipient is A and your donor is O, okay, and that just means your plasma, there's a little bit of plasma in there, your plasma from your donor could attack the recipient cells, all right? Again, that's why it's a minor incompatibility. And then RH should not have too much of an effect unless your patient already has the D antibody, all right? But typically RH wouldn't play a huge role in bone marrow transplants. All right, and so like I mentioned, once your patient's type starts changing, the products must match your donor's type, right? And this can be demonstrated by this chart. So in your example, the major incompatibility, so your patient is O, given A products, notice pre-transplant, transplant, recipient, we're giving them all their own type of red cells, right? Type O, right? Because they were type O. However, once the recipient antibodies are no longer detected, okay, meaning that that graft has taken, the cells are now producing A, then we will switch their type over to A. All right, so during these bone marrow transplants, you have to monitor their type. Once you start seeing your donor cells in your testing, that's when we will change their type. In a lot of facilities, won't really switch their types. You could keep this patient at O, right? He's the universal red cell donor. You could keep giving him O's. All right, and most facilities will probably do that just to prevent any confusion. All right, so just remember, the thing you have to remember is once your bone marrow transplant recipient type change, you will honor that type. So while he was previously an O and he received an A bone marrow, his type is going to change to an A. Okay, at that point, he can receive A products. And usually you would have to maintain that continuously, right? Once those stem cells, hopefully he'll start producing new cells. In the malignancy, he'll go into remission. His cells will eventually start producing again. All right, so we have to keep a monitor on his type. he will eventually revert back, is what I'm saying. And minor, if your A patient received O products, and notice that we just continuously give him O red cells. And then you might even have some major and minor incompatibility. Let's say if your patient is A, but you give them a B bone marrow transplant. Notice that we could start out with group O. And then once the antibodies, your patient antibodies are no longer detected, you can give them group B. But you could keep them at O as well. That's what most facilities are going to do. Just get them O red cells.
Will any of the other antigens like E or L be a problem, or is it just the ABO type?
For bone marrow transplants, typically we only worry because when you do a bone marrow transplant, typically only the ABO antibodies are of concern. Yeah. They typically don't worry about the other red cell antigens, just the ABO. All right, so following a transplant, this is why it's important in blood bank. Pretty much all of these patients are going to need red cell transfusions, plasma transfusions, platelet transfusions. So keep that in mind. These patients are being repetitively transfused with platelets. They have the potential to become refractory. They're either going to build a platelet antibody or an HLA antibody that's going to attack those platelets. At the point where those platelets no longer increase their platelet count, then they either need cross-matched platelets or HLA-matched platelets. Very common for these patients to have that requirement. Here at UAMS, we do a lot of platelet cross-matching, and then HLA platelets if needed. And then platelets are cross-matched. We take patient plasma mixed with the actual platelets from the unit itself, just to make sure that an antibody in the patient's circulation will not attack those platelets. All right, so in this lecture, we talked about autologous transfusions. Remember, autologous transfusions can never be used by another person. And remember, for autologous, they have a quite a bit lower hematocrit requirement, 33%. Okay. And then we talked about apheresis, how we can collect a specific product. And then we talked about hematopoietic stem cells. Remember, in bone marrow and stem cell collection, HLA is more important than ABO, all right? However, if you were doing a kidney or a liver transplant, then ABO is very important. You want to make sure that the ABO is compatible in those. And heart too. So Sarah asked, if you were to donate stem cells, would they give you EPO? So if you're donating stem cells, they will give you some type of colony stimulating factor, such as granulocyte colony stimulating factor, not necessarily erythropoietin, because we're not necessarily concerned with the red cells there. We want the specific hematopoietic stem cells, the pluripotential stem cells, because they have the ability to self-renewal, right? And that's what we want. Another question too. Oh, for autologous, the erythropoietin for autologous, yes, is to make sure that they have enough red cells for the autologous donation, so that we could give them erythropoietin to stimulate red cell production, just so they don't develop anemia from the donation. And then one of the disadvantages of an autologous donation is the increase of adverse reaction from the donation process itself. And that's just all of the normal disadvantages or the adverse effects that occur from donation in itself. You know, like the vasovagal, if they're known to fainting, lightheadedness, all right, those are the most common ones that occur. But then also, you know, if it's a severe, they could go into cardiac shock as well. All right, do you guys have any questions?